Okay, good morning, and thanks to the organizing committee for the invitation, and thanks to Dr. Miriam for this nice debate. As usual, if I want to win a debate, I would like to convince you that I'm going to look smart, even if I'm not smart, confident, but not too confident. I will show some fact, but definitely I'm not going to show all the fact because that will make me look weak. And I will create an illusion at the end that I am the winner, especially if my opponent is not showing up. So, joke aside, I am debating the potential approach of a mitral clip in bridging patients who are a heart transplant candidate. I'm going to give you some reality about the current status of a transplant, the survival of patients with the available therapy, and at the end, I will make you make the decision about this patient with me, about transplant, destination, in addition to the 4 pillars of medical therapy, or a bridge edge-to-edge repair. So the reality of the heart transplant, amazing strategy. We cannot deny that heart transplant outcome is amazing compared to other therapy, but in reality, the current adult survival in a heart transplant, post-heart transplant, is 11.3 years. And if we look at the survival per era, if you follow the green, which is in the 2000, the blue between 2001 to 2009, we could see a meaningful improvement in the survival from 10.2 years to 12.1 years, clearly has been related to our transplant colleague, the surgeon, and the advisors in therapy. But still, if you look at the curve, at least 40% will require either a second heart transplant or they are dead by that time. If you look at the age group, and if you concentrate in the blue lines where the patient age Dr. Amal presented, if you look at their survival, 11.8 years, that's with the current therapy. Now, in reality, who are the patients who are actually being listed for a transplant? 88% are ischemic and non-ischemic cardiomyopathy, of whom mitral valve disease is prevalent. But let's go back and ask ourselves, do we have enough donors? This data is from the Eurotransplant. If you look at the heart transplant per se, it has been steady. There hasn't been any increase in the number of heart transplants from 2014 to 2023. More importantly, it does not follow the population. If you look at a heavily dense populated country like Germany, the number of transplants per million is way lower than a less populated country like Slovenia, where probably this is related to cultural and the availability of a younger population. So, yes, transplants work, but there isn't enough donors. Now, if you look at the data from the North America, from 2000 to 2017, the number of transplants has been steady with no much increase. More importantly, the people who are sick are not being transplanted. If you look at the list of the patients who are in ECMO needing a transplant, those patients is probably not going to be transplanted, and you might need to do some additional work in order to make them listed in the future. Now, let's look at the guidelines published by the Society of the Lung and Heart Transplant. The patient Dr. Amal presented carries 3 of the major mnemonic that we use in the heart transplant literature, which we call I need help. He has clearly had a New York Heart Association of class 2 to 3. You are failing to up-titrate medication. He had 2 more hospitalization. But in this subset of patients, pulmonary hypertension is very important, and if we are waiting in this patient to become or develop irreversible hypertension, he might not be listed. Mitral valve therapy has been shown to reduce the progression of pulmonary hypertension in certain subset of patients. Now, destination therapy for all my surgical colleagues in the room are amazing. There has been an amazing advancement in the magnetically limited VADs, the HeartMate 2, but I want to give you a reality. Survival of patient with the destination therapy, 40% of the patients are dead if you follow them for up to 4 years. Is it something we should consider? Absolutely, but we should not forget that it comes with risk. This is local data from King Faisal about the outcome of patients who are listed on the LVAD, 31% mortality with 8.2% risk of GI bleeding, which is detrimental in future transplant. Now, if you look at the trends of the LVAD since 2010 till 2019, a clear increase in the number of LVAD as a destination therapy. But if you look in the other side of the slide about the outcome at 60 months, mortality is 46.8%. Yes, it works, but the mortality is high. More importantly for a transplant center, since the change in the UNOS listing criteria, patients who received destination VAD dropped their priority in the heart transplant list. Not only that, but also if you are listed or if you receive a destination VAD, you do have significant advantage of preventing the organ dysfunction, getting you out of the hospital, giving you a good quality of life. But remember, you also at risk for an LVAD-related complication that might unfortunately render you unlisted in the future, like stroke. Now, to summarize the data on the heart transplant, absolutely, it's one of the best strategies, but we are lacking donors, and people are dying in the list. This is from the European data showing that 19% of the patients died waiting for a heart transplant. Now, MR absolutely is prevalent in this population. Around 30 to 40% of the patients with ischemic and non-ischemic cardiomyopathy. Not only that, MR per se, if you take MR alone, it is actually a strong predictor of worse outcome in this patient population. So in order to make my case that therapy like mitral valve clip, I need to convince you that it does work, but in way more sicker population at a higher age and an older population. So this is from the COAP trial. Patients with severe LV dysfunction, ejection fraction less than 30%, who were randomized to medical therapy versus mitral clip. And clearly, mitral clip was a winner in terms of mortality compared to guideline medical therapy. And it did not come with more safety concern. There was no disease, there was no device-related complication up to 5 years. The all-cause mortality definitely was better in patients who had mitral clip, but we cannot withhold the fact that we are dealing with a higher population, with a high-risk population, and yes, 50% of the people died within 5 years. Now, the other trial that we need to be aware of is the ReShape heart failure, but this trial took a wide range of ejection fraction between 30, 20, up to 50%. Our patient presented was in the range of this trial, and basically have severe MR. So what does this trial tell us about a patient who does have heart failure, who received the clip? Much more older population, same range of LV dimension that mentioned in our case, in good medical therapy. Yes, they are missing one of the pillar. The SLG inhibitor was not as prevalent in this study, only 10%. So the outcome was clearly driven by heart failure, and we do reduce heart failure with mitral clip. And the debater side of me will love to hide the information about the mortality, but the truth is there was no difference in death between the mitral clip and the medical therapy, yet there has been a clear reduction in heart failure. So the conclusion of that trial was we reduce a combined effect of heart failure and death, driven mainly by heart failure by 36%, clear improvement in the outcome in terms of quality of life, and patient can leave the hospital. So again, the debater side of me who wants to win will not show you the mitral flow data, but I'm going to allude to the mitral flow trial in this slide. It was a negative trial showing no evidence that the mitral clip actually was better. But in a very larger post-approval trial in the state driven from the STS database, they analyzed the patient overall, the whole cohort, but then they analyzed the patient based on whether they are a co-opt criteria or whether they are a mitral flow criteria. The success was amazing, 97% for the implant. The 1 year reduction in the MR was clearly prevalent. The quality of life did improve, so as the lower clinical event. But even if we took the cohort of the patient who we said they might not benefit like the mitral flow cohort, clearly the outcome of those patients I waived my right for the rebuttal. So
Yeah, we told them, yeah. Can you please put it back for another 5 minutes as we agreed? He's going to use his rebuttal time for his debate.
That's a strategy to win.
Yeah, strategy to win.
Thank you. My time is actually 4 minutes. Thank you. So in this trial, even if we looked at the patient who actually were mitral flow candidate, meaning the inclusion and exclusion criteria, they fare better outcome in terms of heart failure. So this tells us that post-approval of the clip, we have expanded the indication and we are seeing clear outcomes in terms of better outcomes for heart failure, although not necessarily mortality. So maybe the difference between the three trials is probably related to the inclusion criteria to the MR. I am not here to debate that. That's a separate talk. But the most important one that I need to address is the mitral bridge trial, which was specifically addressed to this patient subset, patient who had heart failure who are being listed, and either they are actively being listed or we do not know whether to list them or not because we have not concluded their outcome. Those patients were used as a bridge strategy using a mitral clip, either as a bridge transplant, a bridge to a candidacy, or a bridge to decision making. The one-year outcome was published showing definitely a freedom from composite adverse event in 64% of the patient, which is comparable to our patient population. Very safe strategy. The trial outcome for 2 years is actually published in the PCR, and it clearly, when you look at the composite outcome of heart failure or urgent heart transplant or LVAD, a bridge strategy was actually successful. If you look at the mean age of the patient, this is the closest to our patient that has been presented, 59 years old. Similar severe MR, similar LV dimension and TAPSE. The outcome was clearly better when you use mitral clip in those patients who are a candidate. And more importantly, patients did not lose their chances in an elective transplant. In fact, some of them, they were delisted. Now, because I am truthful, I have to say when I reviewed this trial, they did not specify those who were delisted from the heart transplant list, were they truly a serious candidate for the heart transplant or not. So that part I cannot comment on. Now, back to the guidelines of the society that control heart and lung transplant. Clearly, their position statement is very clear. Patients who do have severe secondary MR with an ejection fraction of 20 to 50%, who are symptomatic, if we can offer them mitral valve clip in addition to guideline-directed medical therapy and CRT, their outcome will be better, and it's listed as 2A due to the lack of stronger evidence. So back to the patient. If you look at our patient, he does have pulmonary hypertension. Thanks, Dr. Amal, for providing the slide. He does have pulmonary hypertension. He does have 3 out of the I need help mnemonics. And as such, I would say that probably I would give him a mitral clip to reduce the heart failure admission. It also potentially can reduce his future development of pulmonary hypertension and being delisted. It may even delay the need for a destination or a bridge device therapy. But if you have a transplant, he might also go for a heart transplant if you have a donor, because he will have an 11.2-year survival. The one thing that I did not discuss is the risk of mismatch post-mitral clip in those patients, because I do believe that the risk in this patient is low based on the TAPSE and the finding that you presented, but you could use that against me in your rebuttal. Thank you.